The TRIM2 study is basically looking at the combination of the bispecific agents that have already shown remarkable activity and tolerability with phase 1/2 approaching 150 patients for both teclistamab and talquetamab. I'll be presenting the combination data specifically of talquetamab with daratumumab, and this is without the pomalidomide, which is yet another cohort. So this is the typical heavily treated population, but what I want to call attention to is, at least from what I've seen, one of the most heavily treated populations in terms of prior BCMA therapy. Over 55% of the approximately 30 patients, 29 to be exact, were prior BCMA exposed, which is really speaks to the need for what do we do with these patients after BCMA. And they were also heavily treated with a median of 6 lines of prior therapy, including triple class refractory over half the patients. So with this unmet need population, there were no unusual toxicities, the usual early cytopenias, the usual the dysgeusia taste issues that we've seen with talquetamab and grade 1-2 CRS. But I think what's remarkable about this study is really the efficacy. And it's still early. Our median follow-up was short, only 4.2 months, but the response rate overall was in the 3 different cohorts of talquetamab. The dosing was either every 2 weeks, weekly, or at a higher dose, 800 every 2 weeks. The response rates were approximately 80 to 85%. And so in this population of such heavily pretreated patients, that's truly outstanding. And the responses were quite deep. They were all PRs, but sizable numbers of VGPRs and CRs. And again, the follow-up is short. And when we look at the duration of therapy, all these responders are pretty much on ongoing treatment. And so I think this bodes well. And we also did the translational data to support that. While one could think preclinically, we know that the laboratory's data suggests synergy with Dara and talquetamab, but there could be a theoretic concern because Dara can block T cell function because CD38 is expressed on T cells. But while we saw a transient decrease in CD38 positive, CD8 positive T cells, when the bispecific was added, that came back up again, and we saw the usual cytokines. So I think to summarize, in a heavily pretreated population, perhaps one of the most heavily treated in terms of prior BCMA, in a prospective study, we're seeing response rates of 80 to 85% in a sample size of around 30 and deep durable remissions with the current follow-up.